morning to one and all. Slides are not moving. Yeah. So minimally invasive glaucoma surgery are newer surgical devices as well as procedures that are usually blebless and with small incisions and can be categorized in several ways. Broadly, these can be ones that reduce aqueous production or inflow MIGS, and those that promote drainage, which is outflow MIGS. Whatever the MIGS, generally they utilize natural physiological pathways, as you can see here, trabecular meshwork, ciliary process, and suprachoroidal route. Where the outflow MIGS are concerned, it is said that they open up dormant collector channels, but this is limited by the episcleral venous pressure, and so it is said that very low IOP cannot be achieved, and it is effective only in early disease. So I set about to investigate the safety and efficacy of combining two types of MIGS, inflow as well as outflow, in advanced primary glaucomas and compare it with the current gold standard of phacotrabeculectomy. Of course, phaco surgery was performed with it. Retrospective study of advanced glaucomas, primary glaucomas, who underwent combined MIGS procedure or trabeculectomy with mitomycin C along with phaco. Primary outcome measure was IOP greater than 5, less than 15, less than equal to. Secondary were anti-glaucoma medication, total success, complications, and interventions for these. The surgical steps of combined MIGS all were done under subtenon's anesthesia. Initial KDB was done after patient and microscope positioning. Then phaco was completed, and once IOL was in the bag, then endoscope was introduced into the sulcus, and ECP was done for about 210, maximum 210 degrees. And at the end of the procedure, it was very important to give dexamethasone subtenons. Surgical steps, mitomycin C was injected in all my cases. They were then shifted to the OR, mostly were done topical under sterile conditions, and they were separate side, both superior. First, a rectangular flap was raised, and then clear corneal phaco was done at an adjacent position next to it. Then the trab was completed with 10-0 nylon into 2 to the sclera and 10-0 vicryl to the conch. Where preoperative characteristics were concerned, the two groups were not very different. Combined phaco MIGS had 34 patients and phaco trab 37. Pre-op medications not different, and also the severity of glaucoma. What was different was a slight increased IOP in the phaco trab group and slightly better vision in the combined phaco group, combined MIGS group. Where both the groups were concerned, they were both effective in reducing intraocular pressure, number of anti-glaucoma medication, as well as improvement in vision. When the two groups were compared together, the final IOP was much better in the combined MIGS group, but this was not statistically significant, and neither was the final anti-glaucoma medication. However, where visual acuity was concerned, it was much better, statistically significantly better in the combined phaco MIGS group. Between groups, again, when complete success was concerned, that was not very different, but total success was better in the combined MIGS group. Failure was more in the phaco trab group. So was the serious complications defined as sight-threatening complications, as well as visual acuity worse by 2 or more lines, and interventions also much more in the phaco trab group. So, combination of inflow and outflow MIGS seems to have an additive, synergistic effect, which a single MIGS may not be able to achieve. And this is akin to the combination of anti-glaucoma medications that we use all the time. It can achieve a low target IOP in a very safe manner, and the role of episcleral venous pressure, including that of the collector channels in advanced glaucomas, is still unclear. I would conclude that combined inflow-outflow MIGS, along with phaco surgery, is in the least non-inferior to the current gold standard in advanced primary glaucomas. It is not only much safer, but it has better preservation of vision and avoids all bleb-related issues with lesser number of post-operative interventions. Of course, larger studies and longer follow-up is recommended. Thank you.
you. Thank you, Dr. Vanita. But uh, how much sure you are that you are doing it with a MIGS and without MIGS? So even without MIGS, if it phaco, intraocular pressure comes down to a significant level sometimes.
Not POAT, sir.
So once you put the MIGS, and how do you really individually decide that how much pressure is coming down with MIGS, additional pressure?
I have not put any device, sir. I have used goniectomy as my MIGS procedure, which is the outflow procedure, and ECP as my inflow procedure. And I have studied, and of course not part of this study, studied MIGS standalone versus MIGS with,
Phaco
MIGS and phaco. And I have found that we reduce the IOP by half in phaco MIGS and that of medication by half.
Thank you.
Normally, MIGS is performed in mild to moderate disease, right? So what made you think that it will act equally effective in advanced cases?
So we are utilizing two channels here. We are utilizing not only reduction in aqueous production, but we are also enhancing outflow. So physiologically that makes sense that if we are doing both together, then it might just work.
Yeah, but if the IOP goes too low, and in these very advanced glaucoma where you cannot tolerate hypotony at all, so
hypertony was not seen in any of the cases. Never.